Okay, well, let's go ahead and officially get started. I'm sure we will have more people joining us as we move along, but just to welcome you all to today's Hospital Data Forum. My name is Norm Thurston. I'm the Executive Director here at NAHDO, and this is our second online meeting. We've had in-person meetings in the past, but our second online meeting. We're glad to have you here. But just by way of review, I want to make sure everybody has a level set on what is the purpose of this meeting. So this meeting is for anybody who's interested in hospital discharge data or whatever you call those programs in your state. We recognize that there's some variety in what they're called. But for people who work with those programs, and this is an opportunity for us to support each other as we improve the collection of hospital data, improve the use of hospital data, and highlight sort of opportunities for improvement and for growth. So today I'm just going to run through our agenda real quick. So first, we're going to have a presentation from one of our state members, and they're going to talk about an innovation that they've been working on for a few years now that I think many of you will find interesting. And then we are going to preview a little snippet from our Hospital Data 101, and I will talk a little bit more about the progress that we've made in preparing Hospital Data 101 when that time comes. But then after that, we're going to open it up for a true forum. And we want most of this meeting for every month to be a true forum. So we're allocating roughly 30 to 35 minutes for conversation, for dialogue, for questions of each other, and for contributions. But first, I would like to recognize our sponsors. So the Hospital Data Forum is sponsored by H-Metrics and by System 13, and we're appreciative of their support of our hospital data efforts moving forward. So with that, I'm going to invite Michael Lawson to share his screen. Michael Lawson from the state of Kentucky, and Angela Taylor, also from the state of Kentucky. So let's, when we get their video on and their screens on. Okay, it looks like
I am sharing the screen. Sorry.
There we go. That's great.
All right.
Yeah, there we go. Michael, why don't you take it away, and we're going to hear some interesting uses of hospital data from the state of Kentucky.
Yeah, so thank you for that introduction, Norm. I'm Michael Lawson. I am the Healthcare Data Administrator for the state of Kentucky at the Office of Data Analytics, which is housed within the Kentucky Cabinet for Health and Family Services. The Office of Data Analytics is a team of data analysts and researchers that, again, is housed within CHFS, and we specialize in a diverse array of skills and topics, as you can see on the screen. And we're created to identify and innovate strategic initiatives to inform public policy and provide opportunities for improved health outcomes for all Kentuckians through data analytics. We work with Medicaid claims data, and then the data set that I am actually administrator over is the health facilities and services data, which is our name for our discharge data or administrative claims data. So unhoused persons are more likely than other hospital patients to have a psychiatric diagnosis, to use alcohol, illegal drugs, and tobacco products, to experience violent crime, visit emergency departments multiple times a year, or be readmitted within 30 days of discharge. The medical respite program would be, an example would be if you had heart surgery and no longer qualified to take up the space of a hospital bed, yet you still needed care, then the respite program would either temporarily house you or in some programs find longer term housing and help get someone set up with that. And there was a study in Durham, North Carolina of 29 patients that were experiencing homelessness. And after 1 year, they found that the healthcare charges went down 48%, hospital admits went down 36%, and inpatient days spent in the hospital went down 70%. During the 2022 regular session of the Kentucky General Assembly, Senate Joint Resolution 72 was signed into law, and it directed the executive branch in Kentucky to apply for a Medicaid waiver to cover medical respite care. Section 1959 of the Social Security Act allows for Medicaid programs to offer home and community-based services through a state plan amendment, and enables states to provide a range of services to individuals who may not qualify for institutional care but still require support. So in Kentucky, the Cabinet for Health and Family Services developed the 1959 State Plan Amendment to address the needs of residents with serious mental illness and substance use disorder, which includes children with behavioral health needs, individual at risk of homelessness who need supportive services. Currently, so the American Rescue Plan Act did help some with the funding, but currently most of the funding comes through pilots in communities and healthcare systems. And so that is the need for what we're doing here in trying to prove the need for respite programs is to get Medicaid to approve those funds. So this map shows across the nation the number of medical specific respite programs, and Kentucky has 2. And so in 2021, representatives from the Homeless Coalition in Kentucky and the University of Louisville School of Public Health and Information Sciences took the initial steps to look at what a solution might look like. And they enlisted the Office of Data Analytics within the cabinet to try to create an indicator for people experiencing homelessness. And so one idea came up to use the HFSD to identify unhoused persons, and there was no clear identifier. And so we created a custom data pool that identified unhoused population. And our goal is to identify hotspots in Kentucky that provide evidence for the need of housing and a respite program funding. One thing that helped with this is in 2019, House Bill 444 did allow for the creation of a unique patient identifier within our data. And having this patient ID helps identify the unhoused persons. To do that, we used Z codes. Initially, we were going to use Z59.0 for homeless, but all of these situations, as you can see, all of these codes would apply to someone who would need help by a respite program to recover from, say, my example of heart surgery. We need to show a chronic need for the respite program. And so we started by using people who had visited the emergency department 8 or more times in a calendar year. And we looked at the number of encounters and the charges by the hospitals and the top diagnosis grouped by rank of frequency. And so you can see that this is a statewide issue. This map shows the location of facilities and the counts for encounters, or the counts on the map are of people, the people who came into facilities in these counties. So the facility is in the county, and then you can see the top 5 counties, the number of encounters that correlate with those counties. And as I explained earlier, we're looking at patients with 8 or more encounters. And so when you're looking here at all hospital patients, that's not representative of every patient who came to an emergency department. That is all patients who visited the emergency department 8 or more times, showing chronic use of the emergency department. And you can see that 12% of those charges came from unhoused patients, and 16% of the encounters came from unhoused patients. And so when we looked at the top 3 diagnoses of people who had 8 or more encounters to the emergency department, we found similarities, but notice that suicidal ideations is in the top 3 when we're looking at specifically unhoused individuals. And then with inpatient admissions, we looked at people who had 5 or more admissions. And so again, when we go, well, never mind, the next slide. Here is the map of inpatient encounters in Kentucky, the admissions. You can see that this is where up in the top left, 2166, that's Jefferson County where Louisville is located. And then right in the heart, in the center, 1260, that is Fayette County where Lexington is represented. Those are the big urban spots for Kentucky, and that's why those numbers are higher. But again, you can see that it's a statewide need. And just like before, these numbers on this slide, when it says all hospital patients, that is all hospital patients who had 5 or more admissions for the year. And so you can see that 5% of those charges were because of unhoused patients, 12% were 12% of the inpatient admissions were for unhoused patients. And for the top diagnosed related group for inpatient, we can see similarities again, like we did before, but notice that alcohol and drug abuse or dependence are up in the top 3 in place of septicemia. When we found so far that starting the method we did, looking at just the Z codes, that it appears to be overlooking unhoused individuals. So if you look at Jefferson County alone, there's an estimated population of 10,000 unhoused persons. Now, all of those people probably didn't go to the hospital, but we only caught 2,000 or approximately 2,000 of those individuals. So we think that there's a way to capture more. And so to make this project even more novel, we're looking at comparing the addresses of the county shelters to the discharge addresses so that we can pull those people as well into the group and hopefully grow the size of our data. And so current methods for estimating the unhoused population using Z codes frequency of encounters with hospitals does not capture the entire population with medical need, likely underestimating the need for respite programs. And so this is a work that is ongoing, and I welcome any feedback or ideas or what you're doing in your states, or if you're using your data in the same way. And I look forward to this program growing into more in the future. I appreciate your time. If anybody has any questions, hopefully either I or Angela can help.
Great, thank you. Thank you, Michael. Let's go to the audience for any questions. Does anybody have any questions out there? Just go ahead and raise your hand, and we'll bring you in, or just take yourself off mute. That's another option as well. All right, I'm not seeing any, but maybe there will be questions come up when we have our discussion later today. Thanks.
I'll post.
Hang on, we do have a question. I knew there would be one. Let's see, this is from John at System 13. You're assigning patient unique identifiers to homeless patients. Could you talk a little bit more about that?
So the unique identifier is not only for homeless patients, just the House Bill 444 allowed us to create a patient identifier at all. And so for my data, the health facilities and services data, there never was a patient identifier in that data. We use so initially we get patient information, we create that identifier, and then we destroy the patient information. And that way it's still de-identified, and that identifier is not tied to any other kind of data set. And so it allows the data to still be de-identified, but that identifier, the reason I mentioned it with this program is it is what helped us follow individuals. So I could look back and see who came back in 30 days and who specifically used the emergency department 8 or more times. So
yeah, and I think that's an interesting idea. I am not entirely sure how many hospital programs have unique patient identifiers that they can use for exactly that purpose, right? The idea of looking at repeat care by the same person. So that in and of itself is kind of like a big deal. I'm sure that you see it that way too, right?
That's a presentation in itself, and we had thought about presenting on that. So we're learning. It's a learning process in how we're doing that. We are changing our method and how we're doing that. But yeah, it's been very helpful, and it is utilized a lot for several different requests for data that come in to my program.
Great, thank you. Yeah, I think that's something that Charles and I had discussed before, that not every hospital program has that tool. the ability to create these unique patient identifiers. So Eric has a comment here. I'll see if I can read this. I would love to have a listing of states with an MPI or without an MPI, and what is the argument for an MPI? That seems like a great idea. I don't know how we're going to get that other than maybe just people drop in the chat. Do you or do you not? Does your state have or does not have an MPI? So that would be fantastic. Yeah. And then Michael, are you able to upload your slides as a link here in the chat? I don't know. Not everybody maybe can see the chat, but if you could do that, we could at least those who are in the chat could see that.
Yeah. As soon as I get my screen back here, I'll see.
Okay.
Yep, I can do that.
And we do have a question here from Val at Civic. I'd love to hear you come back with updates on the shelter address method. So as that works its way forward, that's something. And then Kathy Hines from Chia says, does your data have a flag for homelessness, or do you strictly use Z codes to identify? Yeah, that's a good question. So what are the other methods that you use for identifying a homeless patient?
So currently it does not have a flag. That is a good idea. We have flags for other things, like I have a flag for the emergency department or certain procedures like mammograms or cardiac cath. I think we have flags for those. That's something that we could create in the future. It's not something that is in place yet. And so, yes, it is currently just the Z codes. And then we are adding on the idea with tying the addresses to their discharge location. And I'm open ears if anybody has any more ideas.
Great. Yeah, so we have several people here that reported whether their state has, looks like some of you are reporting that you have the patient identifiers like name and social security number. And I think the more interesting question is, because different hospital systems may not code the names the same. I guess if you have social security number, it works. But if you just had names, you still need to figure out how to create these MPI sorts of things, right, Michael?
Yes, and so like I said, we're in the process of changing how we've created it. And I think that don't hold me to this because we're changing it as we're developing it. But it would be name, birthday, insurance ID, and possibly medical record number. There's some other thoughts like using the hospital number to identify that it was the same person, but name, birthday, and MRN gets it down pretty close.
Okay.
As soon as we get that developed, I wouldn't mind sharing what we went through creating that as well. So
I think it's a great idea that maybe the states that are doing this could share their methodology. I'm sure that everybody's doing it kind of their own homegrown way, but it would be interesting to see and compare how that's all working out for everybody.
I would appreciate that right now in my life if we shared that.
Yeah, we've got a question here from Val again. Did you assess whether individuals were still unhoused in their post year?
Not yet. And so this is growing. So the counts that we did pull anybody who had those Z codes anytime throughout the year. And so there were cases where people came in and out of the data, and we kept those people in the data because at least for what we considered was within 1 year, I mean, that's showing instability still in that year. Hopefully, as we do more pulls going forward, get more data, and I will be adding to it. So.
Right. Fantastic. Well, thank you again. Thank you, Michael, for taking the time to pull this together for us and actually kind of pivoting this interesting discussion about MPI. So it's kind of like two things all in one, right?
Yeah, no, and I would look forward to if anybody wanted to share what they're doing with their NPI, then I'm all ears right now. So.
Okay, well, fantastic. Thank you so much. And if you could get a chance to upload your presentation, I think someone would appreciate that. All right. Thank you. All right, we're going to go to our next item on the agenda. So at our last meeting, we talked about our efforts to develop Hospital Data 101. We have a prototype. Let me just put it that way. I think it's reasonably polished, but we certainly want to get your feedback on this. We're going to show you just module 1. It's 11 minutes long. So Charles is going to go ahead and show that on his screen. So it'll be an 11-minute video presentation that gives you an idea of what Hospital Data 101 will look like when it's completely done. I'm also going to put this at the beginning and at the end. We are looking for people who can record just short snippets, testimonials, if you will, just individuals who can talk about why this data is important to you. So if you're interested after you see this, just drop a note in the back end. We just need some people to help us make these little testimonials to kind of spice it up a little bit. So Charles, whenever you're ready, go ahead and hit go. And we'll take 11 minutes for this. Charles, I think you're on mute, so you're going to have to unmute somehow.
To improving healthcare data collection and use. Hey everybody, I'm Norm Thurston. I'm the Executive Director of the National Association of Health Data Organizations, or NAHDO. NAHDO is a national nonprofit membership and educational association dedicated to improving healthcare data collection and use. We've been involved in hospital data since 1986, and I'm excited today to introduce you to our Hospital Data 101. This is an opportunity for you to learn the basics about state hospital data programs. This session will include 4 modules that will introduce you to those programs, the nature of hospital data, how the data is submitted and processed, and most importantly, how the data is used to create value. Thank you for joining us today.
Welcome to Module 1, the landscape of state hospital data programs in the United States. State-based hospital data programs are essential components of the healthcare infrastructure in the United States. They serve as vital sources of information for policymakers, researchers, healthcare providers, and the public, offering insights into healthcare utilization, costs, quality, and outcomes. This module is intended to provide a high-level overview of these programs, allowing an analyst or program team member to understand their purpose, structure, and value. While the specific structure and scope of these programs varies from state to state, they share the common purpose of collecting and analyzing healthcare data. California's Department of Healthcare Access and Information, for instance, has a long-standing and highly regarded program that collects detailed data from hospitals across the state. Similarly, Florida's Agency for Healthcare Administration maintains a comprehensive database of hospital information used extensively for healthcare planning and regulation. These programs serve a multitude of purposes, all aimed at improving healthcare delivery and outcomes. Primarily, they seek to capture population-level information about healthcare utilization, costs, and quality. By aggregating data from various hospitals, these programs can identify trends, disparities, and areas for improvement in healthcare delivery. For example, data on hospital readmission rates can reveal areas where care coordination needs to be strengthened, while data on surgical complications can highlight opportunities for quality improvement initiatives. Furthermore, state hospital data programs contribute to public health surveillance by tracking infectious diseases, monitoring outbreaks, and identifying public health trends, such as hospitalization rates for chronic diseases and injury. Many state public health programs, including asthma, injury prevention, and environmental public health tracking, rely heavily on state hospital data for understanding trends. These programs also use the data to look at measures of preventable hospitalizations that should be addressed with quality primary care. Because there is value in having a national perspective on healthcare trends, almost all state programs are actively engaged in the Healthcare Cost and Utilization Project, commonly referred to as HCUP. This program is sponsored by the Agency for Healthcare Research and Quality and has been in existence since 1988. It includes the largest collection of longitudinal hospital care data in the United States. Using data submitted by state programs, called partners, HCUP produces several products including state and nationwide databases, software and online tools, and reports, allowing researchers and policymakers to compare healthcare trends across states or at the national level and identify best practices. The organizational structure of state hospital data programs varies, but they are typically operated by a state health agency or a designated data collection entity. In some states, like Indiana, Iowa, and Kansas, the authority and responsibility for collecting the data lies with the statewide hospital association, while in others, like Kentucky, Louisiana, and Maine, it is the role of a state agency to oversee the state's hospital data program. Each program has dedicated staff who manage data collection, processing, analysis, and dissemination. The legal authority for collecting hospital data stems from state statute or rules that mandate data submission by healthcare facilities. These regulations often specify the types of data to be collected, reporting requirements, and penalties for noncompliance. HIPAA, a federal law primarily focused on protecting patient privacy and data access, provides a specific exception that permits the collection of protected health information for public health purposes, including state hospital data programs. This exception allows states to collect and analyze PHI for purposes such as tracking disease outbreaks, monitoring healthcare quality, and conducting public health surveillance. Achieving 100% compliance with data submission requirements can be challenging. Limited resources, variations in hospital data systems, and occasional resistance from healthcare facilities can hinder complete data collection. To address these challenges, state programs employ various strategies to encourage compliance, including outreach and education, providing clear guidance and technical assistance to hospitals on data reporting requirements, data quality audits, conducting audits to ensure the accuracy and completeness of submitted data, enforcement mechanisms, utilizing legal authority to enforce compliance when necessary, which may involve fines or other penalties. The scope of data suppliers for state hospital data programs is largely determined by state regulations and licensure requirements. Acute care hospitals, including their emergency rooms, are primary data suppliers. Freestanding emergency departments, which have become increasingly prevalent in recent years, are also sometimes included in data collection efforts. Additionally, many states require ambulatory surgery facilities to submit data, providing valuable insights into outpatient surgical procedures. However, certain types of hospitals might be exempt from mandatory data submission or may not routinely submit data. VA hospitals, operated by the federal government, often have their own data reporting systems and may not be fully integrated into state programs. This can create challenges for researchers and policymakers seeking a complete picture of healthcare utilization in a given state. Charity hospitals, depending on their legal status and funding mechanisms, might also be excluded from data collection efforts. Similarly, mental health or specialty hospitals may have specialized data reporting requirements that differ from those of general acute care hospitals. State hospital data programs collect a wide range of data elements, providing a comprehensive view of hospital activity. These elements typically include patient demographics, like age, gender, race, ethnicity, and zip code, diagnosis codes capturing the patient's medical conditions, procedure codes describing the medical procedures performed, length of stay, admission and discharge dates, and the number of days the patient was hospitalized. Billing information, such as total charges, revenue codes, and condition and occurrence codes that impact billing. Discharge status, including whether the patient was discharged home, to another facility, or died in the hospital. Information about who provided the care and where. And the payer's name, type, and the patient's relationship to the insured person or subscriber. This rich data set serves a variety of purposes, such as tracking healthcare utilization trends, monitoring costs, evaluating quality, informing policy, and supporting research. Tracking healthcare utilization trends. Analyzing hospital admission rates, emergency department visits, and surgical procedures to identify patterns and changes in the trends for healthcare demand can help policymakers anticipate future healthcare needs and allocate resources accordingly. Monitoring costs. Examining hospital charges, case mix, and resource utilization to assess the financial burden of healthcare and identify cost drivers can inform efforts to control healthcare costs and improve efficiency. Evaluating quality. Assessing hospital performance on quality measures, such as readmission rates, mortality rates, and patient safety indicators, to identify areas for improvement can inspire hospital-driven process improvements and empower consumers to make informed healthcare choices. Informing policy. Providing data-driven insights to decision-makers can inform effective healthcare policies, regulations, and payment models. For example, data on hospital readmissions can inform policies aimed at reducing avoidable hospitalizations. Supporting research. Enabling researchers to conduct studies on healthcare delivery, outcomes, and disparities contributes to evidence-based practice. State hospital data has been instrumental in research on topics such as patient safety, health equity, and the effectiveness of different treatments. State hospital data programs face several challenges in the ever-evolving healthcare landscape. Data standardization. Standardizing data submission to ensure consistent definitions and formats across different hospitals and data systems remains a challenge. The adoption of standardized data elements and interoperable health information exchanges can facilitate data sharing and analysis. Data security and privacy. Protecting patient confidentiality while facilitating data sharing and analysis requires robust security measures and adherence to privacy regulations. State programs must implement strong data encryption, access controls, and de-identification techniques to safeguard patient data. Evolving healthcare models. The rise of telehealth, accountable care organizations, ACOs, and other innovative models requires adapting data collection and analysis approaches to capture these new trends. State programs may need to develop new data elements and reporting mechanisms to reflect the changing nature of healthcare delivery. Resource constraints. Maintaining and enhancing state hospital data programs requires adequate funding and staffing, which can be challenging in times of budgetary constraints. Advocating for continued investment in these programs is crucial to ensure their long-term sustainability. Looking ahead, state hospital data programs are poised to play an even greater role in healthcare improvement. Advances in data analytics, machine learning, and artificial intelligence offer new opportunities for extracting insights from vast datasets and generating actionable knowledge. By embracing these technologies and collaborating effectively with stakeholders, state hospital data programs quality, affordability, and accessibility. For example, predictive analytics can be used to identify patients at high risk of readmission, enabling targeted interventions to prevent avoidable hospitalizations. In conclusion, state hospital data programs are indispensable tools for understanding and improving healthcare delivery. By collecting, analyzing, and disseminating valuable data, these programs empower policymakers, researchers, healthcare providers, and the public to make informed decisions that promote better health outcomes for all. Welcome to Module 2.
All right. Thank you, Charles. Thanks for showing that to us. So as I mentioned in the chat, just a few notes here. The first one is that the entire Hospital Data 101 is about an hour long when it's complete. And so it'll consist of 4 separate modules, just like Module 1, there was 2, 3, and 4 to follow up with that one. And the intent is to give somebody who's new to hospital data the basic understanding of how the various programs work, how the data works, so et cetera, so they can feel more comfortable doing their job. We do need a couple more testimonials to insert between the modules so that it's not just an hour of continual watching a slideshow. We wanted to break that up a little bit. So that's the second part. And then we are also planning to provide a script that goes along with this so that someone could read along. I think the final version will have closed captioning as well. So people who need closed captioning will be able to see that. So there'll be multiple options there. So with that, do we have any questions? Okay, so Sumit, thank you. That's a great question. We are hoping to have this ready by the end of the week. That's an aggressive timeline, but that will require us to get those testimonials in. So as soon as we get the testimonials in, I think it'll be like about a 2-day turnaround. So I'm not going to promise the end of this week because of that limitation, but certainly by the end of the month. And then in terms of access, I don't think we've decided that there should be any limitations on this. I think we just want it to be available for whoever. So more likely than not, what we'll do is we'll put this on our YouTube channel and make that link available to you all to circulate to your employees. So, and again, I should have mentioned up front, there were several people who contributed to the outlines and the scripts and reviewed the content so that it works together. And we appreciate all of you that contributed as well. So yes, great question there, Sumit. Any other questions? Yeah, and we did try to keep it simple and not complicated. That was kind of in the back of our minds was, okay, this has got to be for a newcomer, like a 101 level person. And so all of our intent was to get the level right at about that. So they have some familiar with data, but don't understand the programs. Okay. All right, we did have one question. I'm going to make this not a question about the presentation per se, because I think it gets us off on another topic, but it is a very interesting question and nevertheless. So John from System 13 asks, how quickly are hospitals required to report discharges to HCUP for outbreak tracking? And I actually don't know that there is a separate reporting requirement for those sorts of things. So I'm going to let someone from one of the hospital programs maybe comment on that. Is there anybody from one of the programs that can talk about required reporting for outbreak tracking? Anybody know if there is such a thing? If you do, just take yourself off mute and start talking. Pam? Oh, Pam would know. There we go. We have the expert here. Pam, go ahead.
Thank you for the question. So the Healthcare Cost and Utilization Project is not intended for tracking purposes. So that's an important distinction. It's a voluntary program between the federal government. I am the director of the Division of Healthcare Data and Analytics, and it is the division that creates the Healthcare Cost and Utilization Project. ARC is not a regulatory body. We are a research organization, and we partner with various states. So what we do is not intended to, there's no mandate, there's no anything around there. Now, lots of the partners are on the call, and they can speak to how quickly they are able to get their data put together. Some states are able to do it within 6 months at the end of 6 weeks at the end of a quarter. Other states take a longer period of time. And then we purchase that source data when it becomes available. And so states can speak to that, but I just want to clarify the purpose of HCUP is not for surveillance, and there is no mandate around it. It's a voluntary initiative. We do like to try to get the data in real time, but it's for a variety of purposes. The Centers for Disease Control and Prevention actually have data collection systems with respect to surveillance, but that's not HCUP. Hope that helps.
Very helpful. That clears up a lot of things in my mind, actually. So very helpful. All right. Do we have another question here? Okay, yeah. And Eric mentions here from Kansas, if you want to learn about surveillance, you can go to the National Syndromic Surveillance Program. That is another program that is focused on outbreak and disease surveillance. All right, let's go ahead and open it up then for just general questions. Anything that's on your mind. This is a true forum. Now's your chance to say, hey, how do people deal with this, or whatever you want to talk about. Give that a second to throw out there. I do have a couple of questions in my pocket in case we don't have questions, but maybe I'll go to Charles. Charles, do you have anything that you would like to ask of the group? Stimulate conversation?
I nothing is jumping to mind immediately.
All right. All right, I'm going to just throw out one question out there. This is for anybody that wants to respond, but I want to kind of hear people talk about how, if at all, have you in the past, or do you plan in the future to supplement your hospital data by linking to other sources, such as a cancer registry or an all-payer claims database or anything else that might be out there, census data. So just my question is data linkage. What are your thoughts about data linkage? Have you done it? Are you planning to do it? Is it something that you would like to do? Teresa, go ahead.
Good afternoon. Yeah, we have actually been using the hospital discharge data to link to the trauma registry data. And then we have also been using the census data as the hospital discharge data comes in, we are assigning based on their address, the census tract and census block and census ID. So that we can, on our geoanalytics, we can actually get down to, if it's, of course, if it's less than 30 cases, it goes up to zip code. But, that way we can actually get further down in our analysis when we're looking at different disease cohorts, especially around asthma and diabetes and heart conditions. So we're linking to the trauma registry data. That's new and different. And so the reason for that is so that we can look at outcomes for patients related to trauma and how often their utilization of the hospital is after a trauma event. And then the census data. We are also linking to the Experian data. The only downfall of the Experian is not everybody has credit. So, but we are able to assign an average household income to each case as an encounter as it comes in, general education level, and transportation, I think is what we're looking at. So, because we're looking to do some drive time analysis in our data.
Oh, that's fantastic. Yeah, we've heard rumors out there that you could use Experian data to get more like sort of socioeconomic status.
Yes.
And the fact that you're actually doing that is kind of remarkable. So fantastic. We do have a question from Claudine, but I'm going to hold this. If anybody else after Claudine's question wants to comment on either her question or data linkage, we'll come back to everyone else to let you comment there. Claudine asks, has any state implemented the new race and ethnicity codes that OMB recommended last year? And maybe before I jump into that one, Teresa, could you answer just real quick? Do you need legislative approval to link hospital reporting data with those other data sources?
No, because we're not a hospital. We're not a state entity. We have a very detailed contract core service agreement with every hospital in our collaborative. So that's how we're able to do that. But I would think that the hospitals, because census data is public data, that the states would at least be able to do the hospital, if not the Experian. But I don't know if the legislation would be required for that.
Yeah. So were you created by statute, or is this just a completely voluntary thing?
Yeah, our hospitals are all a part of collaborative here in the North Texas region. So, yeah, that's how that works. So we have individual agreements with every hospital/health system, and part of that agreement is the sharing and the matching and all of that we do.
Great. And then yeah. And so your agreement spells out, and when you decide to do something new, you have to consult with everybody and say, we're going to do something new. And they're all saying, yeah, let's do it.
And we have a kind of an executive type committee that's our data governance, and they're the ones who kind of oversee when we go out and do these things. They're the ones that kind of direct what's important, what to prioritize, how we look at getting that data in and adding new data elements to it. So for instance, in Texas, they don't collect preferred language spoken or cell phone number, which probably a lot of states don't, but we wanted to collect it in our collaborative because the cell phone number can be used to help improve data linkage, and because a lot of people keep their cell phone numbers now, even if they move or get divorced. So we wanted to use that for linkage, and then we wanted the preferred language spoken because that helps us in identifying areas in the DFW area that might need more services from a community health perspective. And so our hospitals have started collecting that, even though the state of Texas currently doesn't, although I think the state is considering adding at least preferred language spoken to their data pool.
And then Mary from HCI asks, how many hospitals, I mean, it's kind of hard to define what a hospital is, but give us a rough idea of the volume of participation that you have.
Right now we have about 114.
Okay. That's fantastic. That's enough to keep you busy for sure.
Yes, we are very busy. And then we have all the trauma registry people from all the trauma hospitals. So we're busy.
Fantastic. All right. So let's then pivot over to that other question that came in from Claudine, asking about the new race and ethnicity codes that OMB recommended last year. What's the status? How are people dealing with that? Are you making changes? Is it on your to-do list? Anyone want to jump in and talk about that? And Charles just put the note there. Sumit, go ahead. And then Richard.
Thank you, Norm. In Connecticut, we have implemented it for part of our system. So our APCD now has a new data submission guide, which has been published, which includes the granular race ethnicity according to the new OMB standards. For the hospital and patient data reporting, we're currently in the process of upgrading our internal system so we can start accepting the data in the new format. We've also put together an implementation plan for all of the provider organizations in the state. There is currently in Connecticut a state statute that requires Office of Health Strategy, which is an agency within the state, to put forward standards and implementation plan for all provider organizations to collect this data. And we're getting statuses from other state agencies on their systems to ensure that their systems are in compliance also. So a number of state agencies have already successfully implemented the new standards, and others are in the process of doing so now.
Thank you. And then Richard, I see that your hand was up. Do you want to comment?
Yeah, sure. So Alaska's also been kind of working on implementing those new guidelines. We actually tried to get a head start on it last year, but we kind of had to put that on the back burner due to some staffing transitions. So we're hoping to pick that up again, ideally this year sometime. One of the challenges that we've had though is we're not really sure like exactly like how our facilities and our surgery centers in particular, like the really small surgery centers, are actually like even collecting race currently, because we know we've had like issues with some facilities that just like up until recently weren't collecting race, or they weren't collecting ethnicity at all. And we're not really sure like how to approach like all of our facilities to see how they're currently collecting those fields on their intake forms or in their medical record systems, and like what the feasibility and timeline for them to either make those system upgrades or form changes to collect race in the new format would even be. So that's kind of where we're hoping to explore this year, maybe do like some outreach and surveys just to get a better handle of like how they're currently collecting those fields and how big of a lift it would be to implement the new guidelines.
Okay, fantastic. And then Christopher mentions X12. Christopher, do you want to just comment a little bit more about X12 changes?
Well, thank you. Yes. So last year, one of the maintenance requests that were worked on for within X12 was to help facilitate OMB reporting or race and ethnicity reporting within the claim and the 834. So we added some stuff to be able to facilitate that.
Fantastic. Thank you for mentioning that. For those of you that can't see the chat, Jamie mentions we have linked hospital data to APCD, death registries, and cancer registries, as well as census data using geography. Teresa mentions Texas is still using the 5010 format to collect data. Has any state moved to any type of a newer format? And if so, what new format are you using? That's an interesting. Is everybody still using 5010, or have people done something different than that? And if you don't know what 5010 is, you'll like Hospital Data 101. We cover that in one of the upcoming modules. So just as a teaser there. Okay, well, I don't see anybody who's going to answer your question, Tori. So we'll find out, and we'll get back to you if anybody is using something besides 5010. All right. Well, we are at close to the top of the hour. I'm just going to thank you all for coming, everyone. We're excited to have you here. Charles, could you remind everybody when is our next meeting? Maybe did I lose Charles? All right. Well, I will tell you, our next meeting is going to be in person in Austin, Texas. and that will be on May 7th and 8th. Is that right, Charles?
Yes, that's correct. And this meeting outside of there, the next meeting here virtually will be in August. So on August 19th.
So if you're excited to meet all of these 165 people who are online with us today in person, plan to join us in Austin, Texas. And we're looking forward to meeting you all in person and having a great time there. So thank you all for coming. If you're interested in coming to that meeting in Austin, pre-registration is open. Pre-registration means that you sign up to reserve a spot. You don't have to make any payments until the end of March, so you can just get your approvals and everything ready to go. We just want to make sure that you've got your spot ready to go. All right, so with that, we're going to go ahead and conclude the meeting, and we will see you all in person in May. And if we don't see you in person in May, we'll see you back online in August. So thank you all once again.